Hello! Welcome to another episode of the Imperial Sports Knee Meeting podcast. My name is Ernest, and following our successful conference in January, we wanted to give you a flavor of what made it so special by spotlighting some of our speakers and the topics that had the room talking. In this episode, I'm delighted to share a talk from Mr. Adil Ajuied, consultant knee surgeon at the Fortius Clinic, on the principles of revision ACL reconstruction. Adil talks about surgical goals, associated lesions, the types of graft choices, and his own practical tips and tricks for these challenging cases. And I encourage you to stick around to the end because I sit down with Adil for an exclusive interview that you don't want to miss. Available only if you're watching on YouTube or listening via a podcast platform like Spotify. So don't miss out on that, and let's get into it.
So I'm going to be discussing ACL revision and recapping some important principles and some important take-home messages. It's a lot of material to cover, so it will not be exhaustive, but hopefully we'll get some key concepts. So these are my disclosures, and I'll put these up again at the end. So first, let's just discuss some three key concepts that I think we need to be aware of. We are all acutely aware of structural interdependence and the way that the ligaments, the menisci, and the chondral surfaces within the knee form a mechanical equilibrium and ecosystem. And we repair, reconstruct, and preserve each element, not only for the sake of that element, but it has knock-on effects for the rest of the system. We also know that ACL revision knees come in different shapes, sizes, and flavors, and they each have their own individual personality. And being cognizant of that is really important to help set patient expectations and to help guide care. Broadly speaking, there are three types of ACL revision knee that I encounter in my practice. There's the healthy knee, the complex knee, and the failing knee. These knees have different end goals, and this helps us guide patients and set expectations. The healthy and complex knee can hopefully aim for a full return back to sports and an ACL primary type outcome. Whereas the failing knee, often surgery there is for salvage, is for symptom control, and our end goals aren't the same as for a healthy or complex knee. So what do these knees look like? Well, the healthy knee has no peripheral lesions, has no chondropathy, has a well-executed index procedure, and a clear history of re-injury. These patients are often young and handsome. Then we see the complex knee. So these are knees that have injuries that you've already heard about today. They have peripheral lesions, they have some chondropathy, there's often difficult metalware that we have to manage, and there are tunnel issues, including dilation and malposition. These patients aren't as young and often are overdue a visit to the barber. And lastly, we have the failing knee. So the failing knee often presents with both pain and instability. There may be issues around malalignment, a failing compartment, meniscal deficit, and peripheral lesions. And no prizes for guessing who fills that category. So we have a spectrum of patients that we see, and we have to understand that, and that's really important. Lastly, we need to understand the ACL revision skill set. So we know that what core skills we need to become proficient ACL primary surgeons, and these are skills that we have to finesse, refine, and develop during our training and our career, and they range from patient assessment and selection all the way through to graft fixation and rehab. However, we add to this as we grow and develop as revisionists, and we have to perfect our ability to manage peripheral lesions. We have to be able to manage complex metalware. We have to be comfortable with staging when it's indicated, and we have to integrate LET into our practice. Also, the existing skills for ACL primary, some of them take on a special significance, such as tunnel placement and tunnel management, and as well as graft selection and graft management and optimization. So our surgical goals, put very simply, are to return the knee to a primary in the intraoperative setting, so we're just executing a primary, and also to return that knee where possible prognostically to the same outcomes as in a primary. So let's talk about a few of those skills that we've already touched upon. So first of all, Metalware tips. Good imaging is critical and good radiographs are absolutely essential. Of course, these patients all have MRIs, and CT has a role in assessing for bone loss and tunnel dilation. It's always advisable to identify the metalwork if possible. Previous bioabsorbable metalwork or PEEK can often be drilled through if not removed. But metalware, it helps if we understand what's been used in the past, as that helps managing that metalware. Very importantly, avoid the metalware if you can. If you can retain it, it does not have to come out. And also understanding bone loss. Some devices are associated with significant bone loss, especially cortical bone loss that might compromise fixation when you remove it. And understanding that's important. And then having the right kit available. So whenever I perform an ACL revision, there's 2 sets of instrumentation that's always available. So I always have the Smith & Nephew ACL Redux set. So this is in particular very, very useful and very good for removing femoral-sided metalware arthroscopically. So we have cannulas, picks, awls, screwdrivers in every size, and handheld crown drills for over drilling if all else fails. For removing metalware outside of the knee, I always have the ACUMED Big Blue universal extraction system, and thus far, touch wood, I've never failed to remove anything with these 2 sets. We've already heard about the critical importance of peripheral lesions, and we're all very familiar with them. The one take-home message I'd really like to hammer home is that you have to actively seek out and screen for each and every one of these lesions. You must not expect your radiologist to come and give you the answer in a report. Imaging does not assess laxity, and often in the in the chronic setting, these lesions will appear healed and unremarkable on imaging. So in the same way, in our acute trauma setting, every shocked patient is suffering from hypervolumic shock until proven otherwise. Every knee has a peripheral lesion in the revision setting until you've screened and excluded it. Graft choice. Well, this is always a very topical subject at soft tissue knee meetings. And the right graft, everyone knows what the right graft is, and that's the one that I use. But in the ACL revision setting, it takes on a slightly different significance. So we know that there are patient factors we need to be aware of, including occupation, tissue quality, patient usage and sports, and surgical factors, which I think are often underemphasized and under-recognized, including what you're familiar with, what you enjoy using, handling characteristics, and fixation options. But in the revision setting, there are some other factors we need to consider. And this includes what's previously been used, because it's no longer available for you to use. The fact that you sometimes may need to fill a larger tunnel than you would otherwise have made. And also that also gives us the opportunity with bone block grafts to position our graft eccentrically to optimize graft position. And then other associated injuries such as MCL injuries, etc. So our options are the usual suspects, which include autograft and non-irradiated allograft. Our autograft options you're all very familiar with, and our allograft options include both soft tissue graft options and bone block graft options. Next, I'd just like to chat a little bit about tunnel management and some tips and tricks and strategies around optimizing tunnel management. And it's really tunnel management that starts shifting the dial and turns you from a 2-stage revision surgeon into more of a 1-stage surgeon. So when I started, I was probably doing 50% 2-stage revision, 50% single stage, whereas in my practice now, I'm over 95% single stage revision. So there are 3 types of pre-existing tunnel. There are the type 1 tunnels, where the tunnel position is exactly where you would place it. There are the type 3 tunnels, where the existing tunnel is far enough away that you can ignore it, and there's a good healthy bone bridge between the 2 tunnels. And then there's a type 2 tunnel, often referred to as a MasterCard tunnel, where there is overlap between where you want to be and where the previous tunnel was, okay? So let's have a look at a type 2 tunnel. So this is a type 2 femoral tunnel. So you can see we debride the lateral wall. We can see where the old tunnel was. We can see where the old tunnel is and where we want to be, and that gives us a MasterCard defect. We can over drill and freshen up that old tunnel to get it to bleed and be healthy. We can fill it with an HA screw. There are many on the market. And then we can make a new tunnel just beside it, which allows us to then optimize our tunnel position. Really important to make sure that our two tunnels are divergent. Otherwise, you risk spinning that screw out or compromising that pre-existing tunnel. So here we've moved the tunnel. We can pass the graft and we can see the screw just underneath. Another type 2 tunnel. Here we can see the radiographs of a well-executed hamstring ACL fixed with 2 interference screws. And again, we can debride it, put in a screw, make a new tunnel, and pass a graft. Radiologically, how does this look? So these are our pre-op radiographs, and after the surgery, you can see that we're able to perform a single-stage revision, and you can see a tenodesis has been performed as well. Looking at a type 3 femoral tunnel, excuse the slightly blurred image, but here you can see our new tunnel leaves a 2 millimeter, 1.5 millimeter bone bridge, and we're able to, again, make a new separate tunnel and ignore the previous tunnel. One more type 3. So this is a gentleman who came to see me from New York. He had an ACL performed in the States, which functioned very well for 10 years before, unfortunately, he re-ruptured playing tennis. And we go inside and we can see that, that this could almost be a type 5 tunnel. And we make a new tunnel, a tunneloscopy in the femur. You can see it shows a nice healthy tunnel. A tunneloscopy on the tibia. You can see that we've managed to skirt his tibial screw. So it was a type 3 tibial tunnel as well. And we pass a new graft, preserving as much stump as possible. So radiologically, how did that look? So pre-op radiographs, and these are our post-op radiographs. We've retained both of his screws, and essentially we performed a primary and a tenodesis. Just to touch on 2-stage revision. So femoral bone grafting. This is a case that I grafted. The tunnel didn't need grafting, but the tibial side was significantly dilated, and that was the indication for the 2-stage. But here we put in a bone dowel. There are lots of tips and tricks for getting these bone dowels in. Sometimes they do interfere quite a lot, and they can fracture as you tamp them in. So I often do a step tunnel with a 1 millimeter difference to give me a nice aperture to get into. I bulletize the end of the dowel, and I even chamfer the edge of the dowel, a bit like an IKEA dowel, so that the sides collapse as you tamp it in. And 6 months later, at 2nd stage, you can see it's healed over, and it even has periosteum. So we're just going to go through a couple of really quick guides as to what we do in each situation, and then we'll just round up. So femoral tunnel strategy, type 1, we can over-ream and use, easy and straightforward. Type 2, we can use an aperture screw or with a soft tissue graft to offset the graft in the tunnel, or we can use an eccentrically positioned bone block graft. Excess dilation, we have to stage. For a type 2 tunnel, if it's dilated, we can, or mildly or non-dilated, we can still fill the hole and then use a dowel or a screw to fill the hole, and then make a new tunnel for either mildly dilated or non-dilated. And again, if it's significantly dilated, we stage. If it's far away, we can ignore it, or we can choose to fill it, in particular if you plan to put aperture fixation and you're scared that the bone bridge may collapse. On the tibial side, very similar. So we can over-ream and use if it's dilated or non-dilated for type 1s. If it's a type 2, we can offset ream and use an offset eccentric screw. And again, we can use a bone block as well. And lastly, on the tibial side, if it's far away, which it isn't often, because it's hard to be far away in the tibia, we can ignore it. Otherwise, I usually will ream and backfill type 3 tibial tunnels, because I always use an interference screw on my tibia, and I'm scared that I'll fall through into the old tunnel and break through the bridge. So to conclude, It's really important to set patients' expectations based on the personality of the knee and the patient in front of you. We should be really aware of how the ACL revision skill set differs from the primary skill set, and we need to refine these skills in the context of our practice. Given that my previous faculty colleagues have shamelessly plugged their courses, I'll plug my course. So we've got an ACL revision course in Munich in November. So if anyone's interested, please go and have a chat to the team at Smith & Nephew. And what we want to do is turn the case into a primary, both in terms of outcome and per-operatively. So it should just feel like you're doing a primary. And last but not least, please remember, please be kind about the primary. All of us in here will be revising each other's ACLs. Our techniques differ. X-rays do not tell the whole story, and positive patients have better outcomes. Thank you very much.
Welcome to the Imperial Sports Knee Meeting. I have Adil Ajuied here with us. Thank you so much for giving us your time. You did an excellent lecture on revision ACL reconstruction. It's covered a lot of ground within 8 minutes practically. But I just wanted to ask a little bit about the lateral side procedures that you do. Do you do it for all your revisions? And what happens if the patient already had a previous LET? Does that change your management?
Sure. So in my practice, a revision ACL is an absolute indication for lateral extra-articular tenodesis. So all revisions get a lateral extra-articular tenodesis. If they've had a tenodesis before, in particular, if they were a high-risk primary and had an LET, or if it's a re-revision, then it is possible to revise the lateral extra-articular tenodesis without resorting to a free graft, whether that's allograft or synthetic. So this is one of the reasons that it's very good to stitch and close a defect in the ITB after harvesting your primary tenodesis graft, because that heals into a new sheet of tissue. And once again, you can harvest another strip well localized to girded tubercle, and then revise the LET once again.
Okay. Do you find that with the scarred down nature of that tissue, that you have to kind of extend your incision, take a longer graft to be able to pass it around, or is that you didn't find that was a problem?
Not really. So with a nice large Langenbeck proximally and a nice sharp Mackendose scissors, you can actually release quite a long strip through a very modest incision. In the revision setting, you do have to be very cautious. The tissues are much more scarred down, both in the subcutaneous layer as you approach the ITB and sub-ITB. So it's important just to take your time and not rush.
Fine, but your technique will remain the same. How you fix it and everything would not ever change, not even for a revision.
Absolutely.
Okay, that's lovely. And just so that our audience knows, what do you do for your LETs? How do you fix it?
So there are lots of different techniques for lateral extra-articular tenodesis, and I think that they all get very equivalent results and very good results. In my practice, I like to fix my LET before I pass the ACL and lock the ACL. So I want the knee to be unstable when I apply my tenodesis, so I can titrate the tension on my tenodesis. I don't want it to go on loose so that the knee still draws and has a positive Luckman. And I don't want to put it on too tight, locking the tibia in external rotation. So I pass my tenodesis and fix it into a bony tunnel, which is then fixed with an interference screw once the adequate tension has been applied. That tension is only enough to abolish anterior draw with the foot in a neutral position. No more, no less.
Lovely. Well, that's really great. Thank you so much for giving us your time.
You're very kind.
Thank you so much.
Great meeting. Thank you.